Okay, so now we move to the workshop 4 is a CTO. So the already previous imaging physiology has used 10 minutes, right? So we need more speedy. So let's start with the first speaker is the Professor Jung-Min Ahn. His title is OMT First. Very, very dangerous title for the CTO session. Please, Dr. Han.
I'm sorry to say the OMT First in front of many CTO experts. So anyway, I really respect, admire the CTO expert effort the last 2 decades because thanks to their effort, our PCI procedure is so advanced. But I want to say that there are different levels. My expertise is not that high, but there are many expert Jedi in CTO, but the rare doctors cannot achieve the 100% CTO success rate. So the many CTO experts developed many algorithms. So as far as I know, the CTO expert, particularly in Japanese CTO expert, the CTO successful rate is almost 100%. But the real world and daily practice may not be the perfect. So can opening CTO save the lives? So previous many observational studies show that the successful CTO improved the patient survival. So multinational CTO registry, other, etc. But the successful CTO improved patient survival, or failure of CTO decreased patient survival. So CTO is inherently stable because these vessels are already occluded and no rush to treat them, and medical therapy, other options can be applied. Ischemic extended the follow-up trial, stable disease up to 8 years, no difference regarding mortality. So I assume that the failure of CTO is more dangerous. So CTO is always associated with the procedural complication. Population is 1 to 7%, very high. So contemporary series of CTO PCI always associated with the complication. So someone said that, yes, let's do some randomization. So previously Dr. Park decided to do some randomized trial, decision CTO trial. So initially, we planned to enroll the patient to 1,600 CTO patient, but the enrollment was so slow, so we finished the patient enrollment up to 800, after 800 patient. So decision CTO, we randomization before non-CTO intervention. So in our decision CTO trial, almost 80% of patients had the non-CTO tight stenotic regions. So up to 4-year follow, CTO PCI, no CTO PCI, regarding the primary endpoint, no difference. No mortality difference, no MI, no repeat intervention difference. So in detail, no difference between CTO PCI and non-CTO PCI. No optimal medical treatment. Another trial is a Euro-CTO trial. This is a little bit different from the decision CTO trial. They randomization after non-CTO PCI, so 13%. So randomization 2-to-1 PCI versus OMT, and they show that the decision CTO didn't show that even angina improvement, but Euro CTO showed that angina improvement after CTO intervention. But clinically, no difference between the optimal medical therapy and PCI. Rather, cardiac death and non-fatal MI 2 times higher in PCI, CTO PCI group compared with the OMT group. At 3-year follow, event rate is numerically higher in CTO PCI group. So another randomized trial using the surrogate endpoint, MRI assessed the LVEF at 4 years after CTO intervention, no difference, but associated a higher rate of cardiac death in CTO PCI group compared with the no CTO PCI group. Another random trial, change in the segmental wall thickening at MRI, no difference. CTO intervention or not. So this is a very old trial. This is not CTO, actually ATO. The 24, more than 24 hours infant-related artery total occlusion, open or not, no difference. So this is a contemporary CTO guideline. In patients with suitable anatomy who have refractory angina on medical therapy, after treatment of non-CTO lesion, the benefit of PCI of CTO to improve even symptoms is uncertain based on the decision CTO randomized trial. So enthusiasm for treating these lesions are fueled by retrospective data suggesting improved outcomes for those patients who underwent successful recanalization compared with those who had failed. However, RCTs, the decision CTO and the Euro CTO have not demonstrated improved function explorer or Revasc has been equivocal with regarding symptoms. So only 2B. So this year, the PI of decision CTO and Euro CTO that made another data. They only select the patient with one CTO lesions without non-CTO PCI. So we evaluated symptom improvement after CTO intervention. So look, in the decision CTO patient, non-CTO PCI patient excluded, and Euro CTO patient and combined. We compared the optimal medical therapy versus the CTO intervention regarding symptom improvement. Change in the physical limitation, change in the angina frequency, quality of life, significantly better after CTO intervention. But look at, without CTO intervention, many patients experience the improvement of patient symptom. So this is safety endpoint, death, non-fatal MI, peri-procedural MI, no difference up to 3-year follow-up. So CTO definitely did not improve the patient outcome regarding cardiac death MI, but could improve the patient angina symptom and quality of life. But look at the failed PCI associated with a very high event rate. So do not fail the CTO intervention. If you fail, please transfer patient immediately to the surgery or anyway. So there are some large ongoing randomized trial, ischemia CTO trial, novel CTO trial, around the 2,000 patients. These two trials will give us some more hint whether CTO intervention would improve the patient outcomes. So this is my thought. Data in favor of CTO PCI is entirely for symptom relief, not improve the patient outcome. CTO PCI was not associated with the improvement of survival or clinical outcomes. All CTO PCI procedures carry a risk of complications. Patients who experience these events generally have worse clinical outcomes. Non-CTO ischemic producing significant stenosis would be more relevant and safer target for symptom relief. So please treat the patient medically first, and then treat non-CTO stenotic lesion next, and then please consider the CTO intervention safely. Thank you for your attention.
Thank you, Dr. Han. So next, opposite opinion is by the Dr. Hamazaki. His title is Revascularization First. Yeah. Please, Hamazaki.
Yeah, after previous lecture, I changed my mind. OMT First, but I have to talk from Revascularization First side. So, okay, this is my disclosure, COI disclosure. And I'd like to talk about the reason why revascularization is fast. The first reason is CTO PCI has benefit over OMT. And some report, there are some reports that support this opinion. And let me show you two papers. And one is this paper. And this paper from Assam Medical Center. As you can see, CTO PCI can reduce composite outcome and all-cause death and cardiac death. And the composite outcome is defined as all-cause mortality and MI and stroke and any repeat revascularization. The other is meta-analysis using 32 papers. In this paper, CTO PCI led to favorable outcome in cardiac mortality and myocardial infarction and in all-cause mortality. So I think CTO PCI has benefit over OMT. And the next reason is collateral flow is not enough. And I had FFR data in patient with CTO. This patient is 80 years old male. His diagnosis is angina pectoris. As you can see, a target is here, and the RCA gives good collateral to a distal part. And the guide wire could pass by antegrade approach. Before lesion dilatation, FFR was done. This is FFR. FFR is 0.36, very low. I think it means collateral flow is not enough. Next case is a 57 years old male, his diagnosis is OMI. Same as the previous one, target region is LAD, and RCA gives good collateral, better collateral than a previous one. And as you can see, channel, almost direct channel. In this case, antegrade guide wire could pass. After that, same as the previous one, I performed FFR. In this patient, FFR is also very low, 0.39. FFR in patient with CTO was already reported in 2013. And as my result, same as my result, FFR is very low. And it not depend on condition, with condition, collateral flow, and wall motion. So here is my question. This is a 70 years old male, and his diagnosis is effort angina. As you can see, lesion is here. FFR is 0.58. Do you want to leave this region? I think everybody say no. If you say no, you should treat CTO for the same reason. So this is my opinion. So collateral flow is not enough. Final reason is that technical issue of CTO PCI has been mostly resolved. As you know, CTO PCI procedure is already well established. CTO PCI was started with a classic antegrade approach, antegrade wiring, parallel wire technique, and IVUS-Guided wiring was established by Dr. Suzuki and Dr. Kato and Dr. Tamai mainly. After that, retrograde approach was established by Dr. Kato. Recently, 3D wiring and TDADR are established by Dr. Okamura. He's there. In use of these techniques, we can perform a CTO PCI with high success rate. This slide showed success rate of CTO PCI in 2022. This data from a Japanese CTO expert registry. As you can see, guide wire success is 97%, and the technical success is 94%, and the procedure success is 94%, and the patient success is 93%. I think we don't have reason to hesitate CTO PCI. So this is my conclusion. CTO PCI should be done first for the following reasons. CTO PCI has benefits over OMT. Collateral flow is not enough, and the technical issue of CTO PCI has been mostly resolved. Thank you for your attention.
Thank you, Dr. Hamazaki. It's time for the discussion. It's from the panelists. So is there some comment or question? So I think considering the time is, please ask one question for each other.
Yeah, okay. Let me kick off the ball. You see, the thing is, the talk is CTO. So you're lumping everything in, either you have CTO or no CTO. But I think CTO is not just either or, because they're different. They're long lesion. There's whether you have good collateral, whether you have multi-vessel disease. I'm sure some of you would have come across CTO. You open it, the wall motion improve, right? And so I think we have to start from what kind of patient we choose to treat before we treat it.
I think I fully agree with your opinion. Definitely, this is very important. So next trial, I introduced the ischemia CTO trial. The one inclusion criteria is the documentation of ischemia. So I think previously CTO studies, Euro CTO and decision CTO trials, the documentation of objective ischemia is not mandatory. So I think that this is very important for the future trial.
Professors? So?
Yeah, I prefer agree to the Dr. Yamazaki's opinion because, we already know about the recent trial, decision trial, and registry found no difference in mortality between OMT and PCI group. But CTO PCI is appear to be beneficial in certain subgroup. Yeah, so we have to define the real CTO PCI indication. So even CTO lesion is not culprit lesion, but sometimes we need to intervention for the patient light quality, I think.
Okay. So we are moving to the next section, the CTO PCI in 2025 who truly benefit. The first presentation is Dr. Jung-Kyu Han from the Seoul National University Hospital. IVUS-Guided CT wiring, what every operator should know. Okay, so, Dr. Han? Sorry, yeah, we are very fast. Sorry, yeah. So, yeah. So, yeah, please.
Thank you, Chairman. I am Dr. Jung-Kyu Han from SNU Hospital. Let's imagine that you are in no man's land, looking out to escape. So, map should be helpful, but it isn't enough. You need a compass to align the real world and the map. The real world is the angiogram, and map is IVUS, and compass is the concept of IVUS-guided wiring. So it's all about aligning angiogram and the IVUS. To make an alignment, you need first you need to understand the orientation of images. Chest X-ray is always displayed from the doctor's point of view, looking at the patient. So this is left and this is right side of patient. To keep this orientation, CT or MRI is displayed from the feet looking at the head side. But the IVUS is the opposite. So the IVUS displays image from head looking at the feet direction. To be precise, is proximal looking at the distal. Here's Korean angiogram. So IVUS image is displayed from proximal looking at the distal, but most coronary segments run from head toward the feet. So you can just simplify it by saying that IVUS image is displayed from head looking at the feet. So this is here's patient, and here's angiographic system. When the system rotates from LAO to RAO, then the orientation of the IVUS rotates clockwise because image is displayed from head looking at the feet. So that's the really fundamental key to understand the alignment. But it isn't enough because when you advance the IVUS over the wire, IVUS catheter can be rotated to any direction. So you need to fix only one point. It's something like using compass. When you use a compass, you need to fix the north point, and then you can tell the directions. So first, you need to fix one point. If there's a good side branch nearby the CTO segment, then you can use that side branch. Or more commonly, you can use the relationship between IVUS catheter and the IVUS wire. So first, you need to find the projection giving you the overlapping between the IVUS catheter and wire. In this case, area 30 degree gives you the overlapping of the two, and then 90 degree apart from this angle should give you the wide separation between the two. But 90 degrees difference usually makes out of working range, so you need to compromise the angle to some extent. Let's say in this case, area 29 degree gives us the wide separation. And on this, from this projection, you see the IVUS catheter is located on left side, and wire is located right side. Then the LAO view should look like this, because from this projection, wire is located on left side, and IVUS catheter is located on the right side. And then where's area view, here or here? This one is incorrect. This is correct, because as I already presented, from LAO to RAO corresponds to the clockwise rotation. So that's it. You made the alignment. So if the true Lumen is located here, then your second wire should target here, this is true Lumen. Then from the RAO view, your second wire should be overlapped with IVUS, like this on the angiogram. And from the LAO view, your second wire should target the left side on the screen here. So now, after the alignment, you can tell the direction where to go on the angiogram. If true Lumen is located here, then your second wire should overlap with the IVUS catheter from the LAO view. And for the RAO view, your second wire should target right side on the screen here. So using this relationship, you can know where to go and where to escape. But not all the coronary artery run from head toward the feet direction. For example, this RCA and OM branch run from left side to the right side on the screen. So how can you make alignment for this segment? By using this relationship, you can easily tell cranial to caudal makes a clockwise rotation with IVUS. So for those segments, you can use this relationship. And more recently, Dr. Okamura, who is the chairman of this session, proposed 3D wiring, also known as tip detection technique. This is a question from his lecture. When your second wire is located here on the IVUS, how do you manipulate the wire? Clockwise or counterclockwise? The answer is we don't know, because if there's no wire shaping on the tip, then when we rotate the wire will be just spinning there without any directional movement. So that's why you make wire shaping, and we need to find where the tip is located. And then if you find the wire tip is like this, then we easily know that the wire should be located clockwise on the IVUS. But how can you manipulate it using torque on our hand? Because if there's no curvature, then when we make a clockwise torque, then wire makes a clockwise rotation, and counterclockwise. The problem is if there's one curvature, then when we make a clockwise rotation torque, then wire tip moves counterclockwise and counterclockwise, clockwise. So from our hand all the way to the end of the wire tip, there are so many numerous curvatures. So it's very hard to understand how to expect the wire movement on the tip. But you don't need to worry about that because IVUS catheter is always located nearby the wire tip. And then the projection is from proximal, look at the distal. So when you make the wire clockwise torque on your hand, then you will see the clockwise rotation of the IVUS. And when you make a counterclockwise torque, then always wire moves counterclockwise. So the direction of the torque is also is always the same as the wire direction of the tip on the IVUS. So it's very easy now. The concept itself is easy. So wire tip is located here, then you make clockwise rotation on your hand. And if the wire is located here, then you can make a counterclockwise rotation. So you need to find the rotation, location, and shape of wire tip on the IVUS. And the second wire should have a tip node and is 9 gram. And first curve should be made with 45-degree and 1 millimeter length. But for successful technique, we need to use anti-or IVUS. And opticross IVUS has quite different from this IVUS. Anti-or IVUS has very short length from transducer to the tip of the catheter, 8 millimeters, but opticross has 20 millimeters. Of course, we can cut the IVUS, but it will make a blunt end, making huge friction. So delivery of the IVUS catheter through the calcified region should be very tough. And another difference is this very long monoline beyond the transducer is 26 millimeters. Opticross has only very short 16 millimeters and before the transducer. So with the anti-or, we can smoothly move the IVUS catheter transducer inside the CTO segment. So opticross is not good for the 3D wiring. So there are some pitfalls of IVUS-guided wiring. First, it's very difficult to deliver IVUS catheter through the calcified top region. So frequently, we need to make a pre-dilatation with 1.5 or 2 millimeter balloon. And frequently, we need to use 8 French guiding catheter. And there are also pitfalls of tip test technique until IVUS catheter is not available in South Korea. And we need to use a very hard tip wire, like Concast Pro 12 ST, sharpened tip, but this wire is also not available in South Korea. And we also need a very skilled assistant for this technique. So in conclusion, and basics of IVUS-guided wiring is it's just aligning angiogram with the IVUS. And IVUS shows us the proximal looking at the feet. And from LA to RA rotation corresponds to clockwise rotation with the IVUS. And the alignment is usually made using the relationship with the IVUS transducer and the relative position of first wire. And wire tip on IVUS rotates with applied the same direction with applied torque direction. Thank you for your attention.
So, thank you, Dr. Han. So we are moving to the next presentation. The next presentation is Dr. Ho Lam from the Chu Mung Hospital, Hong Kong. The title is Tip CTO, Same or Another Beast. Okay, so please.
Yeah, thank you, Chairman, and good afternoon, everyone. I hope Chairman can give me 2 more minutes for this presentation. I will talk about TRIP CTO through this case. The patient was 56 years old, smoker. He was initially admitted for heart failure. EF was just 20%. At that time, chop eye, CK were all normal. We initially planned to do angiogram, but the patient had LV fungus and emboli and then hemorrhagic transformation. So we can't do it and stabilize, make sure all the fungus go away. And then we do the coronary angiogram study later and then found the patient had triple CTO. So we did MRI, EF was just 23% 2 years later, and surgeon of course declined PCI, so we try to do PCI on this case. So it's a 3-course CTO procedure, so we go for starter. This was the angiogram of the patient. You can see the third was CTO. In fact, the AD is total subtotal. I give a very forceful injection, we can see that there's a track. Yeah. AD and outside is CTO. So for this case, we quickly finish the AD. And then we do PCI on the circumflex. Initially, we underestimate this CTO lesion. We think it's quite easy. It's just simple. And then we try just wire with EBU, strong guiding, and then filter XT, R, and A. But we failed. The wire went into subintimal. And more than that, there's some hematoma. You can see some dissection, some contrast staining. So you adapt this picture. This is the procedure. It's a real-time record and those hemodynamic. You can see that here. Yeah. But now we already finished the PCI on the left side, so the retrograde supply is actually very, very strong. Yeah. So we try go to the main course. So this we try to establish access for retrograde and also do the access through the impeller. In fact, you can do CTO procedure or complex procedure through the impeller access. We just input a shift over there, and then use. This time I changed the strategy. I use a soft guiding 6 flange. Okay, this time I use just a 6 flange Hyperion. And then I use strong wire, parallel wire. Because you see the CTO segment is very short, I want to use a very strong wire, but not strong guiding. And then try to search the proximal cap and then try to puncture it. And this is a real-time recorded case that I was done a few years ago. So we can see, we can try to search. Sometimes this may help because you can see if the guiding support is also very strong, you may push through the proximal cap but may puncture into some cross perforation or whatever. But I feel that I just caused the proximal cap, but I go to a side branch. So when doing all this tube case, my experience is you always need to know when to slow down, when you need to speed up. Like this time, if I do anything wrong again, probably this procedure will be very complicated. So I need to slow down, make sure focus on the 3 elements, your imagination line, your wide field, and also some contrast inject, and then with visualization to make sure you see carefully, and then I try to redirect. And then in the distal cap, I try to rethink carefully what should I do first before I go for another step. Yeah. That are all the essential elements in those tube cases. If you do more, you will feel that sometimes a minor mistake, you just want to be hurry and then will cause us great disaster. Because those cases are very fragile. You will see later, demonstrate to you that what happened. So now I feel that I'm in the true Lumen. And you see all along stable. Do we really need the impeller support for those tube case? So I check carefully to see if it's true Lumen or not. So you can see the retrograde is very strong. This time it's true Lumen. So now nothing happened, right? So you see the whole procedure is do through the impeller shift, 6 flange guide. It's okay. But the problem of this soft guiding, it can help, but the issue is you may not able to cause the lesion. Like this case, I tried very hard with Turnpike, Sapphire, I cannot cause this lesion. But no problem. I prefer to use this guiding in this sort of situation is because this guide, actually you can transform it into very strong guiding. Just with the help of the guide extension, you can transform the JL into EBU4. Okay, now it's EBU4. Then you have enough support, you can cause it. You need to be very careful, make sure you don't make any dissection, any perforation or loss of wire. And then we open it, we open by small balloon, and then we exchange to workhorse. And after that, we did the angiogram check, everything okay, and then we do the IVUS. Make sure it's 2 to 2 first. So prepare for the dessert and surprise. The main course was, and yeah, it really surprised you. And from the IVUS, it's 2 to 2. So trust me, and then open with 1.5 balloon. look at the hemodynamic, focus, listen. Maybe you just see it once in your life, yeah, okay. And then we open with a small balloon. And then my assistant was like, oh, finish the procedure, very relaxed. But suddenly, you look at the BP. What happened? Look at the hemodynamic. No left main dissection, nothing. I can promise you, there's no perforation, nothing happened. What happened? How to settle? Yeah. Now I'm confident I know what happened now. So I'm confident. But you can see the BP. You must settle in 5 minutes. Without impeller, maybe you must make diagnosis, treat it in 1 minute. It's a live record. If you cannot make it in 1 minute, the patient will die. We can start the discussion over here. What's your diagnosis? How will you treat? You can see the pressurized flatten. The aortic valve cannot open. There are two lines. Yellow is the right side guiding, so it must be a true pressure. It's not artifact. So don't think about that. You don't need MGS for chip case. Many of the time you had done nothing wrong, no perforation, nothing happened. I just opened it, and then the pressure like that. Now you see no left main dissection. Now 1 minute off. Yeah. After 1 minute, how to treat? The patient is arrest. Probably with this MCS, maybe it's your first time to see stable arrest, and then you can have time to think. But still, you must treat it in 5 minutes. Otherwise, the patient will also die, or you need to step up to ECMO. So the patient now is flattened. Nothing. So panel and Choi, how will you treat? What happened? Yeah, it's real record. You can see the timer. Yeah. That is chip CTO, chip case. If it don't happen, it is not real chip. For all this real chip case, even you've done nothing wrong, something can happen, or in case some minor mistake, the patient can collapse like that. So what happened? Oh, I give my answer. In fact, it's due to all these chip case. You need to be careful about full equilibrium. You can imagine a very critical AD, and this AD supply the whole area, make the patient survive. So any disturbance on the equilibrium, like this time we open the CTO, in fact, the pressure, we are lucky or unlucky, the antegrade pressure and the retrograde pressure are just equalized. At that, if this happens, the patient will present like this: bradycardia, pressure drop, the heart do not move. Imagine you have done nothing wrong, but the patient can still arrest like this. So we have to settle it. How to settle it? The principle is to speed up the re-equilibration of the blood flow in this chip case. So for this case, our strategy is give IV fluid, give inotrope, and at the same time, put a stent on the antegrade, increase the antegrade flow, then make sure the antegrade can get over the retrograde. So I try to put the stent in, and always remember, master the fast and master the slow. This is a very good case. Maybe you just see once in life, see the whole arrest process in a stable way. If it's not regular life, probably I dare not to wait so a long time. So I need to quickly put the stent in. I still have time. Within 5 minutes, still okay. More than 5, I cannot guarantee. So we put the stent in, and then check if okay, then stent. I know you have lots of questions over there. So I go away because you need time for the balloon to deflate. You cannot be hurry. The time the balloon deflate, and then you can take it out. You can see the whole arrest process, all the timer, second by second. And then we take out the balloon. When that means the antegrade flow will re-establish, and the pressure on the antegrade is stronger, and it can take over the retrograde flow. So we still have 10 seconds to 5 minutes. Let's see. Focus on the hemodynamic. Yeah. Now you see the retrograde completely disappear. The antegrade fold actually take over, and the hemodynamic, the BP come back. Yeah, that is chip CTO, real chip CTO. Yeah, very good for, and the AD also nothing happened. And this approach is completely fine. You can see that the access is completely okay. Patient few months later, EF increased to 40%. So it's difficult to say no benefit for all patients in CTO PCI. Class 1 after 3 months. And that is the question, who truly benefit to CTO. I think after Jung-Min's presentation, we know that, and I know that there's no randomized data. We really need to jump out of this question. Don't think about the patient, think about ourselves. Can we do the procedure better so that the patient can get benefit? No failure, no complication. So my theory is to direct your team into these 3 areas. Good clinical judgment, select a good patient, and also good skill and good device. Just skill is not enough. Like this case, without the device, without the MC support, the patient die hard. Yeah, that is my presentation. Thank you.
Okay, yeah. Thank you, Dr. Lam. So, yeah, the time is limited. So we are going to the next presentation. The next presentation is Shozo Ishihara from the Mimihara General Hospital. His title is Tips and Techniques of the Dual Lumen Catheter. So please.
Thank you for Chairman. So I will talk about a little bit clinical tips. But so at first, I totally agree with Dr. Ahn. So we don't have to. We never fail the CTO. So because the CTO failure is unbeneficial for the patient. So that we should brush up our skills, and also of course patient selection is also very, very important. So as you know, the CTO PCI benefits are shown like this. So of course, symptom is the most as how can I say that evidential. But another quality of life or left ventricular function also one of the clinical benefits. And also the problem is still randomized trials are limited. So is it still controversial? Dr. Hamazaki against to this evidence. But so for appropriately selected patients, this is also very important. CTO PCI provides clinical benefits, as you know, and therefore we should brush up CTO PCI skills and techniques. I will focus on tips of dual lumen catheter because, of course, IVUS-Guided wiring is also very beneficial, already presented. But IVUS catheter is limited for usage in some countries because of the economical reasons. But dual lumen catheter is maybe available in all countries. So that I will focus on this one. So there are so many efficacy of dual lumen catheter like this. But this is a CTO session. So only a strong backup for CTO guide wire crossing is one of the important benefits. And this is a global CTO crossing algorithm. Sorry. And so this is antegrade wiring and so parallel wiring. In this point, so double dual lumen catheter is effective. And also tips and techniques of dual lumen catheter, especially for CTO lesion. So as I mentioned, strong support for antegrade wiring and parallel wire technique is very, very important as in the algorithm. And also another topics are the bifurcation and also the rescue for side branch occlusion and bifurcation CTO. Sometimes we use the balloon screen technique and also reverse wire technique. I will mention a little bit so each issues. This is a bifurcation. I will show the left main CTO lesion. This is looks to a subtotal occlusion. And so this is a post bypass surgery so that later ITA graft is patent for the LAD. So that the patient still have the chest pain and also circumflex lesion is ischemia. So that I try to treat the circumflex. And this is a guiding catheter, but it is difficult to engage. And wire crossing is also very difficult. XTR ultimate blows difficult. And fortunately, in this timing, pilot 200 crossed the CTO lesion of left main. But tip angle is very small, so that it could not insert into circumflex, only LAD. At this timing, of course, we know, oh, dual lumen catheter is very nice for this situation. So we use a Sasuke dual lumen catheter and also the wire seal. It is easily close to the circumflex. And after that, so we could put the stent and post dilation. And so final result for circumflex is very nice. Of course, LAD was bypassed. So in this kind of case, so dual lumen catheter was very useful. Maybe, as you know, expert CTO doctors, of course, know. And another one is a rescue for side branch occlusion. This is a right coronary CTO lesion. So I'm sorry, the image is not so clear, but so this is a CTO of the distal part of the RCA, and this is truly CTO. So I just started from antegrade approach with using XTR wire, but I failed antegrade approach. So that start retrograde approach, but also failed. But it's a problem. This is a live demonstration case in overseas countries. So that I tried antegrade approach again, and fortunately, the Gaia wire passed to the PD branch. But sometimes we face this situation. So after the 2O balloon dilation, so PL branch, this is a bifurcation after the CTO lesion. So sometimes branch disappeared like this, and Sion black wire fortunately passed the opposite side of PL branch with using dual lumen catheter. And after kissing balloon, we put the deploy the stent, and final result was acceptable. We can survive for both branches like this. So this kind of bifurcation lesion is one of the good indication for dual lumen catheter. And another top tips I want to share. This is a circumflex CTO lesion. So RCA is totally small vessel, so that the circumflex is very big in this patient. So using 7 French guiding catheter, and I use a dual lumen catheter to advance the wire into the circumflex, this branch, and also XTR wire can catch the entry, but unfortunately the wire is easily collapsed like this. So wire is inserted like this, but if I push a little bit strong, easily collapse to the main branch. In this kind of situation, we sometimes use a balloon screen technique. We open up the small balloon, and so this is a blockage of the collapse of the wire. And then, fortunately, I can advance more strongly to the CTO branch. So, okay, I advance the wire, but unfortunately, this wire is also in the subintimal space. So that in this situation, I can use once again dual lumen catheter for parallel wire technique like this. So second wire is advanced like this, and then change to the dual lumen catheter to single lumen microcatheter. But single lumen microcatheter also easily collapse to the main branch side. So that once again balloon screen technique. This kind of changing mind, next option is very important for this kind of CTO procedure. And after stent implantation, this is a very big branch of the circumflex I could recanalize. And the final topic is a reverse wire technique using dual lumen catheter. So maybe most of doctors know this kind of procedure, reverse wire technique. So we use a dual lumen catheter, one wire on the dual lumen catheter, and the second wire was bended like this and inserted and pull back like this, and so advance to side branch. So we I show this CTO case. This is a right coronary CTO and already bypassed, but so bypass graft of the saphenous vein graft was 99%. So that I don't want to open up this saphenous vein graft, so I do the right coronary CTO PCI. So this is a dual injection. This is a CTO lesion like this. And in this situation, I started antegrade approach with using ultimate bloss and Gaia next, but not passed. So I started retrograde approach. But I don't want to make ischemia of the distal part. So small balloon, I just dilated to keep the microcatheter space. And then advance the microcatheter, but yeah, small band dilation and advance the microcatheter and also wire. But this anastomosis, sometimes we use bypass graft for retrograde approach, but anastomosis angle is difficult to cross the wire. In this kind of situation, dual lumen catheter sometimes helpful. So using Sasuke and also Sion Black, but unfortunately I couldn't cross the region. So that in this situation, I do the reverse wire like this. This is a reverse bend, and fortunately tip is face to the anastomosis side, and like this, and advance the wire to the distal right coronary. And after that, I change the dual lumen catheter to normal single lumen microcatheter and change the wire for CTO wire, so from retrogradely. And after that, advance the retrograde wire from this side, from microcatheter is already here. And so we can do the reverse cut technique. Maybe you can understand. So after the reverse cut technique, the wire was crossed and externalized. And then finally, 3 stent was deployed. And the final result was very nice. I couldn't success this case without using dual lumen catheter. This is also very important for anastomosis wire crossing. Reverse wire technique is very nice. So this is our final slide. Of course, we use dual lumen catheter for parallel wire technique, bifurcation, side branch occlusion, and balloon screen technique, and reverse wire technique. This is a very important tips. Not to fail the CTO procedure, and making best use of DLC is a key technique of successful CTO PCI. Thank you for your attention.
So thank you, Dr. Ishikawa. So just now we are open to discuss. So are there any questions or comments?
In my experience, the first part, the OMT is very important. I think that totally agree with Dr. Ahn, and the OMT is very important. But OMT is the basic treatment before doing considering the doing CTO of the PCI or not doing the PCI. But my experience, some CTO doctors have the same situation. I think that I have several cases that I regret not to do the CTO case, RCA, big RCA CTO, and the patient refused to do the CTO PCI, and I let them do the OMT only. But after several years later, this patient have the LAD AMI, and we cannot rescue the patient. And some patients have the CTO, and after that, several years later, have the AMI, and it to the different coronary artery. And at that moment, if the CTO is procured, then we can save this patient. We have not so many cases, but several few cases. But with that case, I feel that the patient saved by the CTO PCI. So it's not extended to the every cases, I assure, but we have several these small cases. We should consider about that.
Yeah, Dr. Kong.
I think the problem of the randomized studies is that many patients who really need CTO opening are not entered into the study. So the patient, the real benefit, the doctors will not randomize the study. So that's the reason why we get these intermediate results. That's a chronic problem. Unless you enroll every patient, you will not be able to see a positive result. If you exclude the patient that they really need the procedure, that there will be equipoise.
Okay. Dr. Hora, I have one question. Yeah, thank you for your nice presentation and case. So, can you define what is the cheap CTO? Because in general, CTO PCI is included in CHIP. So I think your approach based on the anatomical complexity. But nowadays, we have to approach the prefer to clinical situation-based approaches better outcome for the cheap CTO. So, what's your opinion?
I think a very good question. It's very difficult to answer this question. I can just say that the real chip or non-real chip, sometimes it looks EF very low or anatomy very complex, but you do nothing happen. But around 30 to 40% of those so-called chip case, you do, the patient will arrest. You just touch, the patient will arrest. For real chip, my definition is during your procedure, either you touch balloon or you water or whatever, the patient's BP go fat line, then this is real chip. I think it's retrospective assessment for real chip. You touch, the BP will fat. That is my experience. In our center, more than 30% of case, I mean the chip case is like that. You touch, the BP fat. Yeah.
I have a small quick comment regarding the optimal medical therapy. And the fundamental limitation of optimal medical therapy is that we can tell whether there's a viable myocardium or significant ischemia only after we recanalize it, because the sensitivity or specificity of the current modality, including MRI, PET aspect, ranges from 50 to 80%, and those sensitivity and specificity was calculated after the recanalization. So gold standard was actually the recanalization. So that's why we can only clearly tell whether there's ischemia or viability after we recanalize that. So that's why we try to open up the CTO if it's feasible.
One comment is, CTO failure cases, maybe the miss rate was relatively higher, but the one reason is the complication, and the another reason is that of the region. So because of the very severe difficult region, so that's why they failed. So that's why there are another difficulties or regions around the another collateral. So that's why the another reason of the unsuccessful cases has a high success rate. So maybe my thinking is try to do the safer and good intervention, but the difficult, maybe stop it and leave it, and medication is another option. Yeah, that's important. So are there any comments?
Yes, can I comment about the IVUS-guided wiring? So Dr. Han, so the Dr. Han finalized the conclusion as the LAO to RAO always means that clockwise, but partially true, but partially incorrect. So we have to care about the vessel course, vessel vector. So if the LAO and RAO is coaxial to the vessel course, no meaning by IVUS. I mean that the proximal RCA.
Yes, it's a very important point, and actually I pointed it in my presentation. So for the distal RCA or OM branch passing through left to the right side on the screen, in that case, we need to use a cranial decoder. In those segments, cranial decoder corresponds to clockwise rotation. And if for both those segments actually run from head to feet, like a proximal LAD or medial RCA, for those cases, we can say that LAO to RAO corresponds to clockwise rotation.
So I have a question to the Dr. Okamura. Regarding the tip detection method, so Professor Han already told us that in Korea is anterior IVUS, and also the Conquest Pro ST is not available. So if in these situations you recommend is the use of the tip detection method, so maybe we need a more first Lumen expansion needed. So what do you think?
Yeah, I agree. And the tip detection method is a rescue method if we don't have an IVUS. So if we do the antegradually or retrogradally, or maybe the antegradually, if we have already the big hematoma or the subintimal space, or the after stingray, try to do the Boston IVUS tip detection method. But firstly, first guide by advancing, then advance the Boston IVUS into the subintimal space or something. Maybe it's not better. So that is a rescue technique using the Boston IVUS. So are there any comments?
I want one comment. So it's Dr. Takamura's question. I'd like to answer some question because it's a very simple. It's a vector. It's a one line. If vessel straight in line, so cranial caudal is similar with the right areolar. So you imagine the one vessel is straight. So you can see the same vector in the caudal and cranial caudal and areolar. Yeah.
And also that kind of fusion is very important. So if the two lumen located on the angiographic image right side, left side, yeah, that's very helpful. So yeah, difficult to try to do the IVUS tip detection method, but that key concept is very important. I have one question for Dr. Ishihara. So yeah, sometimes I try to navigate the guide wire, single guide wire manipulation to the target, but the guide wire is not entered into two lumen. Then sometimes I will rewiring just a little pullback and direct guide wire tip to the next approach. So when you will going to the pile wiring using the double chamber catheter, single wiring, rewiring is the another choice. As you sometimes switch to the pile wiring when.
Yeah, so it's a very important. For example, if depends on the situation. If the wire is intima, so in the plug, it is sometimes okay to change the rotation and also so 3D wiring something. So, but if the wire is subintimal, we know it is always difficult to rewiring again. So that if the wire course seems subintimal, it is better to quickly change to the parallel wiring to avoid hematoma enlargement. Is it the answer?
Yeah, that is the correct. Yeah, sorry. Yeah, thank you.
Dr. Ishihara, so you show us so many tips and techniques. So do you prefer some dual lumen catheter? So for example, so you always use the some unique brand or some, is there some preference for the dual lumen catheter?
It's a very difficult question. So in Japan, we have the two dual lumen catheters, Crusade and also the Sasuke. So it's a little bit different. Crusade is more supportive, and Sasuke is more crossable, very lubricity. So that it depends on small channel is better for Sasuke. And so strong puncture for the side branch. At that time, Crusade is better. So it's my opinion. I don't know other brand in China or in other one. I'm sorry. It's okay?
Okay, so yeah, the time is limited. So yeah, we are closing this section. The CTO is improving, intervention is improving, and also still the very hot topics, I feel. So a nice presentation. Thank you for your attendance. So we are closing at this section. Thank you. Sorry. Yeah, sorry. Very rushed. Yes.